All right, let's talk about something that gets every surgeon's heart racing, the consultant viva exam. Today, we're going to jump right inside one of the classic scenarios, using an official exam document to create a step-by-step guide on how to absolutely nail the fistula in ano station. Let's get into it.
So this scenario we're about to break down, it comes straight from the Saudi Commission for Health Specialties, or the SCFHS. If you're a surgeon prepping for this exam, you know the stakes are sky high. You see, it's not just about what you know. It's about proving you can think on your feet, stay systematic, and remain calm under some serious pressure. So let's imagine we're in that exam room right now.
Here's our game plan. We're going to walk through this case exactly like you would in the real exam. We'll kick things off with the scenario itself, then dig into how to take a killer-focused history, what to look for in the clinical exam, how you build your diagnosis and differentials, and finally, the management. All the key principles that are going to score you those top marks.
Okay, take a deep breath. You've just sat down across from the examiners, the clock is ticking, they look you in the eye, and they start the case.
And that's it. That's all you get to start with. Just one simple sentence. It's short, it's direct, and now the ball is totally in your court. Everything you do from this moment forward is being evaluated, how you structure your thoughts, and most importantly, how safe your approach is.
And there it is, the first question. How would you approach him? Now, this is an open-ended question, and it's a bit of a test. A panic candidate might just blurt out a diagnosis, but a strong candidate, you start with the fundamentals. You lay out a clear, confident plan. I will approach this patient by taking a thorough history, followed by a detailed physical examination in order to formulate a differential diagnosis and a management plan.
And that fundamental starting point is always a really thorough, focused history. This is your first real chance to show the examiners your systematic approach. It's where you start collecting the clues you need to solve this whole clinical puzzle. Every single question needs to have a purpose.
So the key here is to show you're not just fishing for information. You'd say clearly, I will take a detailed history covering, and then you run through these key points. You ask about the discharge to figure out its nature. You ask about pain, bowel habits, and bleeding to rule out red flags, things like cancer or inflammatory bowel disease. And this last one is absolutely crucial. You have to ask about a history of a perianal abscess. Why? Because up to half of all perianal abscesses can end up forming a fistula. It's a massive clue.
And the examiner gives you the answers. Now let's unpack this, because you've just been handed a ton of information. 6 months? That points to a chronic problem. No pain or bleeding? That kind of pushes things like an acute infection or malignancy down the list. But the real bombshell is that last sentence. He had a previous IND and incision and drainage of a perianal abscess. That is the classic story for how a fistula in ano develops.
So you've gathered that critical history. The examiner is going to push you forward. What will you do next? Well, the logical next step in any clinical situation, and especially in this exam, is to move from talking to doing, from the history to the physical examination.
You'd state it confidently, I will perform a full physical examination with the patient's consent and a chaperone present. Again, you're showing that you're thorough, safe, and systematic. You always move from the general to the specific.
And this is that systematic approach in action. You start with the basics, general appearance, vital signs. Then an abdominal exam, to feel for any masses or tenderness that might hint at something like Crohn's disease. But the real meat of it is the local examination. On inspection, you're looking for that external opening, where it is, any signs of inflammation. Then, the digital rectal exam, the DRE. Here you're assessing sphincter tone, which is so important for surgical planning, and you're gently feeling for a tract or an internal opening. A proctoscope is the final step to help you actually see that internal opening, right at the pectinate line.
And boom, here are your findings. An external opening at the 3 o'clock position, and crucially, you can feel the internal opening. The fact that you can feel it, and given the location of the external opening, this is pointing very strongly towards a simple, low fistula. You've now got a consistent story from the history and clear findings on exam. It's time to put it all together.
So, with all this info in hand, the examiner is now going to test your ability to synthesize everything. They're not just looking for the most likely diagnosis. They want to see that you've considered other serious possibilities too.
So they'll ask, what is your differential diagnosis? And right after you state what you think is most likely, this is where you really show the breadth of your knowledge. Just giving the most obvious answer isn't what a top candidate does. You lead with your main suspect. My provisional diagnosis is a simple fistula ano, most likely secondary to a cryptoglandular gland infection. But you can't stop there. You have to mention other important causes.
Mentioning Crohn's disease is a critical safety point because doing a fistulotomy on a patient with undiagnosed Crohn's can be a disaster. It can lead to a non-healing wound. Mentioning specific infections like TB shows you're thinking broadly, and of course, trauma is another key thing to consider. This is how you show you're thinking like a consultant.
Okay, we've arrived at the money station. You've diagnosed the patient, now it's time to treat them. This is where you need to be confident, clear, and super precise. You have to cover not just what you're going to do, but how you're going to do it and why.
The examiner asks the big one. How are you going to manage this patient? Your answer here needs to be a complete package, covering everything from the pre-op chat and consent to the specific surgical procedure and your reason for choosing it.
And here it is, the winning answer. First, you say you'll get informed consent, which has to include risks like bleeding, infection, recurrence, and really importantly, the potential impact on continence. Then you state the procedure, an examination under anesthesia, or EUA, followed by a lay-open fistulotomy. And you should be able to describe the steps. You position the patient, confirm both openings, pass a probe through the tract, and then you incise the tissue over the probe, laying the whole tract open so it can heal from the bottom up. For a simple low fistula, this is the standard of care.
Now, if you really want to impress the examiners, you show them you understand the underlying principles. They might ask, how can you predict the fistula's path? Your answer should be, Goodsall's rule. And then you just explain it simply. Openings in the front of the anus usually have a straight tract, while openings in the back often have a curved tract that opens in the posterior midline. It just shows a much deeper level of anatomical knowledge.
Another high-yield topic is classification. If they ask, you absolutely must be able to state Park's classification. This system is all about the relationship of the fistula tract to the sphincter muscles. And it's fundamental, because the treatment totally depends on it. A fistulotomy is safe for intersphincteric and low transsphincteric fistulas, but it would be a disaster, it would cause incontinence, if you used it for a supra- or extrasphincteric tract. Knowing these is just non-negotiable.
So, you've navigated the whole scenario perfectly, but let's end with one final thought. The biggest pitfall here isn't just messing up the diagnosis or treatment, it's failing to talk about the full patient journey. After you describe the surgery, a top candidate will also mention post-operative care, sitz baths, pain relief, and fiber to keep stools soft. They'll also talk about following up to check on healing and discuss red flags like recurrence. Thinking through that entire process, from that very first sentence all the way to the patient's final follow-up appointment, is what separates a pass from a distinction, and that is how you ace this station.